You're listening to Beyond the Endpoint, a podcast from the Duke Clinical Research Institute. In this series, we're demystifying clinical research and answering your pressing questions about health and healthcare. You can find our full episodes at dcri.org/BTE.
If you spent any time on social media lately, you've probably seen at least one allergy video pop up in your feed. We're seeing a lot of activity in the allergy space. Environmental allergies could be getting worse, a shift in guidelines may have positively impacted peanut allergies, and the FDA-approved Xolair for food allergies. Allergies affect so many people, and it can be challenging to follow the most current science. There's no shortage of misinformation online, so I'm really excited to hear from our guest here today, Dr. Zach Rubin. He's a double board-certified pediatrician specializing in allergy and immunology at Oak Brook Allergists in Chicago. You may know him from his huge presence on social media, where he breaks down science in an approachable, evidence-based way. He also has a new book on the horizon, all about allergies, that we'll get into as well. Dr. Rubin, Zach, thanks so much for being here.
Thank you so much for having me. It's really nice to have this conversation and talking about allergic diseases.
Yeah, I have a 20-year-old son and an 18-year-old daughter. My daughter grew out of egg allergy. My son still's got a pretty significant nut allergy. He's very careful about it. But these are things that a lot of parents probably are dealing with. And so I really appreciate you thinking about it. And I guess before we get into all of the stuff around allergies, tell me a little bit about yourself. How'd you get into medicine? How'd you get into this space?
Yeah, so I grew up in the Chicagoland area. My dad's a general pediatrician, so it's been a part of my backbone forever. Back at a time when the primary care physician did everything, right? You would do a spinal tap on a kid in the ER, admit them to the hospital, round in the morning, see your patients in the clinic, and then round at night and just rinse and repeat. And I saw that. It's like medicine was a calling. It was something that you just lived and breathed. And I became drawn to it at an early age. I met with a lot of my dad's patients following him around, and he would talk about the critical thinking that was involved and how what you were learning was just constantly changing. And that really fascinated me, that you can help people in all sorts of different ways. But in medicine as a physician, you're not only helping people, but you do it in a way that really humbles you. You really start to get an appreciation for life too, because you see all aspects of it. And so I decided early on in high school, I wanted to go to medical school, and ended up at Case Western Reserve University through their pre-professional scholars program. So I did undergraduate medical school there. I then went on to do pediatrics residency at University of Illinois in Chicago, and then did fellowship in allergy clinical immunology at WashU in St. Louis. So the challenge that I faced was that I finished my fellowship right at the beginning of the pandemic. And so when I went from St. Louis to the Chicagoland area, even though I went back to where I grew up for private practice, the connections weren't there because everybody was shut down. I was trying to find what is some way I could reach out and grow my practice. And I saw everybody was online. Everybody's on social media, trying to find some human connection when we didn't have it in person at that point. And so I went to Twitter initially and connected with a lot of great physicians, nurses, scientists, and even patients that way. And I realized that there was just so much misinformation on the internet about healthcare, about science, about medicine, vaccines, COVID-19, even allergies.
Right.
And so took it upon myself to start educating people about what was the reality of the situation, what's the real nuance, what's evidence-based medicine like, how to critically think about these things. And slowly but surely, I became encouraged by people to start making video content, because it was initially just typing it all up. And I went to TikTok thinking, oh man, this is just a kid's dancing app. What am I doing here? And I didn't realize at the time, until I started really getting into it, that there's a whole community of physicians and scientists who are trying to educate people online, because that's where the vast majority of people get their information now. And I stuck with it. I learned how to do everything in terms of creating the idea, filming it, editing it, posting it, interacting with people. And it grew from nothing to now over 4 million followers across multiple platforms. And having a book coming out and being a speaker and going on podcasts and being a medical contributor for ABC 7 News, and just seeing myself everywhere. And it's really made life so interesting, because I take all the skills I learned from social media and I apply it with my patients. My patients often follow me on social media, and they come to me already feeling comfortable with who I am. So I establish that rapport. I start learning about what people are wanting to learn about, and knowing that, hey, I know this really well, or no, I got to learn more about this aspect of whatever it is. And so it helps me become a better physician and a better communicator. so that are really distilled down the complicated issues. Science and medicine have a hard time taking that language and distilling it down for the general public.
It's really a powerful story. And actually, I find it in the training programs and the work we do here too, that the best physicians, the best clinicians are people who can communicate. It's probably true of all aspects of every industry, but really in medicine now more than ever, it's a big need to be able to communicate in a hopefully just as direct and as clear way as possible. Because I think people are really hungry for trusted sources of information where they feel like they can approach people in a humanistic way, in a humble way, not many of the answers we don't have, as you know, and
Right.
part of that is being direct about that.
Yeah, there's so much gray zone in medicine that we don't communicate enough about, that everything is better when it's black and white and there's certainty, and that's often how things are communicated online. But the reality is life is very complicated. Most people don't fit neatly into boxes, and that type of thinking often causes a wedge in trust. And being able to communicate clearly the evidence, the expertise, and the nuance, I think really helps connect with people better, and hopefully we can build back trust that way.
Well, I really appreciate what you've been doing, and it's really inspiring and powerful for a lot of people who are thinking about how do they make a difference. And maybe to start that, like, as an interventional cardiologist, I know maybe the least amount of immunology one could imagine, but how do you describe the basic biology and immunology behind an allergy? Or, what's the differentiation between, I'll call it, allergies and sensitivities, something we see all the time?
Yeah, and language matters so much in medicine for those who are listening, that when I talk about these terms, they get confused quite a bit. And so the first I always talk to people about is, what is your immune system? What is it actually doing? A lot of people think it's just protecting you from infections, but it does a lot more than that. It's involved in wound healing. It's involved in figuring out what is self versus non-self. How does your body know that food is safe to consume and not a germ? These are a lot of questions that we don't always think about and take for granted, that food can actually be poisonous for people, potentially, depending on how your immune system looks at it. It's important for cancer, right? We have cancer cells in our body. When a cell that normally functions to do a specific task has a genetic mutation, it starts becoming non-functional. And your immune system is tasked with finding those cells and destroying them before it becomes larger and potentially malignant. And the immune system is not housed in one area. It's throughout your entire body. It's not just your lymph nodes, but there are cells in your skin. There's cells in your lungs, in your gastrointestinal tract. And so when we think about how the immune system functions, then we can branch out and say, all right, what is allergy? It is literally an abnormal immune system response to a foreign substance, versus a rheumatologist and autoimmune disease is an abnormal immune system response to your own body. That's what lupus is about. That's what Hashimoto's thyroiditis is about. There are also folks who have a primary immunodeficiency disease. It's rare, but that's where the immune system just does not function properly and can't protect you against infections. Most people have heard about HIV/AIDS. That's a virus that causes a secondary immunodeficiency, where it tanks an important type of cell called a T cell, making you susceptible to infections. But it's not all one issue. There's multiple aspects to this. So when we talk about allergy, there's actually multiple different types of reactions you could have. And if you understand the science and the underlying mechanisms, there's different types. We often refer to it as Jelen-Coombs classification for hypersensitivity. And I can see the wheels are turning from like medical school, right?
No, it's really good, because we think of the immune system, as you said, as a very highly responsive to infection. That's how most people think about it. But as we know through medical school and then through practice, it's really a surveillance system throughout your whole body.
Exactly.
It's doing a surveillance all the time. I'll call it like the sentinel. It's always looking for, where's the break? Should we go support this? Is this us? Is this not? And where can I heal? I'm involved in a lot in cardiovascular medicine. We've thought a lot now about how the immune system is actually so critical to how the heart heals, or we prevent plaques from happening in these chronic conditions.
Exactly.
Chronic elevated inflammatory scenarios where we're sort of always making, to your point, this self, non-self solution. I think that construct's really helpful to people, because I think that'll help them understand when you get into conversations about, well, is this an allergy? Is this a real allergy or a sensitivity, or the immune system's being activated in different ways? Maybe walk us through that a little bit.
Yeah. So we have a clearly defined knowledge base about allergy, and we're still learning more. So you could look at a specific pathway, as I was briefly mentioning earlier. there's type 1 hypersensitivity reaction. So that's the one that people are most familiar with, because when you think of a food allergy or a medication allergy and you develop hives quickly after exposure to that, the underlying mechanism is the generation of these proteins called IgE antibodies, immunoglobulin E. Now, you may have never heard of this before, but why is it that it's called IgE? This is just for those who are interested in the sciences and historical context. When they started learning how to do skin tests for allergies, and you take a drop of a substance and scratch the skin, what happens is if you have an allergy, it would cause redness or erythema, immunoglobulin erythema, IgE. That's how it was essentially named. And so when you make those specific antibodies, it's a process called sensitization. That initial exposure kind of primes your immune response so that on subsequent exposure, if you have the specific ingredients in place, mast cells, IgE antibody, the actual allergen itself, the substance that it's worried about, it can cause those mast cells and potentially basophils to activate, releasing chemicals like histamine that create symptoms like itching, runny nose, hives, swelling, problems breathing, vomiting, a combination of those symptoms, or even a drop in blood pressure, which we refer to as anaphylactic shock. That's the life-threatening situation that could even cause a heart attack in rare instances. And so once you understand that pathway, then you compare it to sensitivities, which is not a specific term. We don't understand the underlying mechanism to which sometimes people believe that when they eat food, they have specific symptoms that happen with it. And so it's not to say that it doesn't exist. What I want people to understand is when you don't understand the mechanism of a disease, you can't have a reliable test to be able to diagnose it properly. So when you go online and people are saying, we have a food sensitivity test, it's $300 for 100 foods that we can do a panel, that's based off of unverified, unscientific testing. The classic examples, they'll measure for an antibody called IgG, immunoglobulin G. And when that happens, they try to claim that it causes you intolerance or sensitivity, when the reality is that those antibodies are made so that your body can tolerate the food. It's the exact opposite of what they're trying to sell. So if I was to help measure tolerance for a food, I could actually get a blood test for IgG antibodies to show that you've been exposed. And I'll get patients who come in with packets where it says they're sensitive to coffee. They drink coffee every day, so they're exposed to it. So it's going to be positive, right? It's not clinically meaningful. Just because there's a test, and this is something I talk about all the time in social media, just because we have a test for something doesn't mean it's relevant, nor is it helpful. Testing can actually be harmful in different situations.
Yeah, a really key point there, because there's going to be a test for almost everything. And really the question is it a validated test? Does it tell me something that's meaningful, biologically plausible? But more importantly, is there something I can do differently that will actually make a difference based on that test? And
change that management, exactly.
well, tell me a little bit about the current allergy landscape. Raising a couple kids with this, there was I'll call it a sea change that was from at least for peanut or not, like don't expose or do expose. Now it's a paradigm shift of like to prevent allergies, exposure. When is the immune system ready to start to tolerate things and our understanding of that?
Right. So to start this off, allergies in general have been on the rise for over 30 years now. We see that with not just food allergies, but allergic rhinitis, hay fever, asthma, eczema. All of these things have been increasing, especially in countries like the United States, the UK, Australia, New Zealand, etc. And we don't fully understand why this is the case. But when we talk about food allergies specifically, in recent times, the American Academy of Pediatrics came out with guidelines specifically for children they believed were at higher risk of developing food allergies, those who have more severe eczema, as an example. That's a whole other topic we can get into if we have time. But they made those recommendations thinking we should delay introduction of highly allergenic foods for this specific population. And there wasn't a ton of evidence to make those claims because the studies were not there. And to make those studies happen, they're very hard to do, and you would need patient buy-in. So the evidence was not the best for that type of recommendation. And what ended up happening was there were observational studies, epidemiologic studies looking at Jewish children in England versus Israel. And they noticed that the peanut allergy rates were significantly lower in Israel compared to in England. And they realized, oh my gosh, these kids in Israel were getting this peanut snack called bamba as babies. They hypothesized that early exposure to peanuts could potentially lower the risk of developing a peanut allergy. And that's where the Learning Early About Peanut or LEAP study came into play, which was published in about like 2014, 2015, around that time. And so what they did in that study was they randomized families to have their children either consume peanut products before they turned a year old, about 4 to 11 months old, or delay it until they were 5 years old. As you can imagine, with clinical research, if you're going to ask families to consent to a study like that, that's a big ask. Hey, your child may end up developing a food allergy based on this intervention that we're trying to do. Are you okay doing that? That's a big question to have answered. That's why to get that study off the ground was tremendous, to be able to do something like that. And they did it, and they found that there was a roughly 80% risk reduction in developing peanut allergies in the children in the early introduction group. That is astounding. But that number, in the context of everything, is only part of the story. Obviously, it didn't completely eliminate it. So there's other issues going on that we still need to learn about. And now the more recent guidelines is saying early introduction for pretty much all the allergenic foods. We want to have a more diverse diet to help reduce the risk, but it's not completely eliminating it. We're just starting to see studies coming out that these recommendations that are now over 10 years old are starting to see a decline in peanut allergy rates, which is tremendous, but we have a long way to go before we actually fix this problem.
It's a great story in how we have our best scientific concepts of what we're trying to do, and then we get some observational data to say, hey, maybe there's a different one. And then you do the really hard work of doing a randomized trial with families and kids to get an answer that's going to help public health. So it's, again, back to sort of, beyond the endpoint, the name of our podcast. It's like not just how the study happened, but how did we get there and what does that mean? So I think it's really powerful. And it's in that perspective that the FDA just approved another agent for food allergies, something called Xolair. You want to tell us a little bit about that and what the science and the sort of findings and reasons that's happening?
Yeah. So Xolair, the generic name is omalizumab. It's a monoclonal antibody, meaning it's lab-grown antibodies where you have, one type, mono. And so that medication was actually developed initially as a food allergy drug, but then was repurposed to asthma and approved by the FDA in 2003 to treat severe allergic asthma. And then the different indications like chronic hives and nasal polyps were added on. And then most recently, it came back to where it started, which was IgE-mediated food allergies. And so the Outmatch trial was another trial that was a huge deal because they randomized children and adults to either getting this injectable medicine every 2 to 4 weeks based on their body weight and their total serum or blood level of IgE antibodies. They would do every 2 to 4 week injections either of the medicine or a placebo. And then they had to do double-blind placebo-controlled oral food challenges, meaning you don't know what they were eating. They didn't know if they were eating the food that they were allergic to or not, and coming in multiple times. And they did this during the beginning of the pandemic. So there were parts of the study group that had to stop and then restart the entire clinical trial. All the families had huge buy-in. They really wanted to answer this question of how is this going to help our patients? And so all of these patients, it was almost 200 of them, they had peanut allergies plus 2 or more foods. And pretty much across the board, 2/3 of the patients were able to tolerate a significant amount of what they were allergic to during those food challenges. So 2/3 were able to consume about 4.5 peanuts without reacting. That is a type of protection that if you have accidental exposure, you're covered essentially. Now, again, not 100% effective, nor is really most of these types of medications, right? And it also depends on the food. So cashew allergy didn't have quite as good of data. Only a little under 50% met that primary endpoint. And so it really involves a nuanced discussion about the potential risks and benefits of this medication. And then how does that impact your daily life? So I don't feel that this medication is meant for everybody that has a food allergy because of your lifestyle factors, the risks of the medication itself, your food allergy profile. I mean, there's a lot of different factors that go into this for medication that if it's not approved, it's unaffordable. It's an extremely expensive medication. So it's one that I only give in my office because there is a risk of having an allergic reaction to that injection too. There's a lot of layers to this that it's not one simple 2-minute discussion.
Lots of kids that are at different stages, running around, different levels of activity, different risk, different levels of actual reaction. So each family is going to be working with hopefully professionals like you and others to have that conversation. But it's always great to have another, I say, arrow in the quiver when you're a clinician and say, okay, not everybody's going to need it, but I'm glad to have something for that family with its child who's really at risk. Are there other exciting developments in the field of allergy medicine?
Anaphylaxis management, the severe allergic reactions, we've classically given epinephrine through the form of an injector, auto-injector like EpiPen or Auvi-Q. Recently, the FDA approved the first needle-free alternative that's a nasal spray called Neffy, and it's approved for children 4 and above who weigh at least 33 pounds, as well as adults. And the exciting aspect is not just that it's needle-free, but it lasts significantly longer than an auto-injector. So it lasts for about 2 to 2.5 years, and it doesn't have the same type of temperature storage requirements. It's much more liberalized. So that's very exciting. And then sometime this month or next month, we're supposed to hear about a sublingual strip. If you ever think about those Listerine strips, it's called Anafilm. You put it under the tongue, that's your epinephrine dose.
Having something long lasting is great. Not having to change out EpiPens and different things like that. So having an inhaler or something like that that they can use as a nasal inhaler would be really powerful. And then the strip is pretty exciting. And I can think of even cardiovascular needs for that. There's all kinds of ways that we would imagine that being powerful. What do you think about metal allergies? I hear a lot about that. As an interventional cardiologist, I have patients occasionally have told me like, oh, doc, I have a nickel allergy. You can't, what kind of stent do you have? And so I've gone through the conversation about people with different sort of like implantable metallic allergies. What's your thought on that?
Yeah, so nickel allergy is the most common contact allergen in the United States. So if you wear jewelry, if you've got a belt buckle, if it contains nickel and it's on your skin for a prolonged period, it can create significant rashes on your skin. We call it contact dermatitis. If you've ever had poison ivy rash, it's the same type of underlying mechanism. We call it type 4 hypersensitivity. And it can be very itchy, painful. You could potentially have a secondary bacterial infection involved with it too in severe cases. And so a lot of folks are wondering, why is it that in Europe, they have less of this compared to the United States? And it really comes down to public policy, which is in Europe, they have high standards for the amount of nickel that could be emitted from jewelry. It really comes down to just regulating products. It's not much else. And so in the United States, when you have nickel exposure, you are more likely to be exposed to the metal itself than in Europe, based on how the products are made. It's also, from an allergist perspective, exposure and the timing are key. And so we have more evidence to suggest that if you were to pierce a baby's ears with nickel, they're more likely to become sensitized than if you wait several years. So it's better to delay exposure in that situation, which is counterintuitive to what we're talking about with food allergies. But again, we're talking about different mechanisms of allergy. It's not the same type of allergic reaction. Therefore, we know from the evidence that delaying and minimizing exposure makes a lot more of a difference when it comes to a metal like that. And that's not the only metal people can be allergic to. You can be allergic to a lot of them. Cobalt is another classic example.
Yeah, we get the cobalt question too. And it's really interesting. I mean, I didn't know it was public policy that much. Good news for our families. My mom only wants old Indian jewelry, so we're probably okay with no nickel exposure. But, I suspect that there's some real risk there. And I think it's actually helpful to parents who are thinking about like when to pierce ears for little girls or boys and when they want to do these different things. I guess, are there any big misconceptions or misleading remedies or things you get asked a lot about?
This is, I think, really important for just anybody listening in general. It's not even just about allergies specifically, although it does apply to it. When you see advertising that says this is all natural and organic or hypoallergenic, these are buzzwords that don't mean much. Natural doesn't necessarily mean safe. This is very simplistic in nature, but arsenic is natural. That's not safe. So just because a label is like that doesn't mean it's helpful. I mean, I just saw a video recently from somebody who's got a very large platform. I'm talking tens of millions of followers, who made the claim that he gets rid of dryer sheets to be toxin free, but then he'll take a wool ball and put essential oils in there as the replacement, which that's basically saying you're going to, have a non-alcoholic beverage by replacing beer with wine. It's the same thing. That is a type of misconception I see so often where there's wordplay to confuse people into knowing what is safe, what is not safe, what you should and shouldn't do. And so you got to be careful about the language that people are using to communicate a story or make a recommendation.
Yeah, no, I totally agree. And in fact, I sometimes call it the regulated and the unregulated environment. Imagine all the things that a therapy whatever that therapy is has to go through to get FDA approval. And then all the things that somebody's just selling you something directly to say, hey, this is a natural supplement. They didn't have to go through that evidentiary standard. So just be wary if you're taking those kinds of things. I'm not suggesting they can't be helpful. I'm just saying they don't have the same bar. Not that I want everyone. I actually tell a lot of my patients, I'm trying to do this without using medicines or other therapies in the general. There's all kinds of lifestyle things we want people to do.
Exactly. Yeah.
But if you're interested in natural solutions, it's hard.
Right. And it's not just about getting it approved by the FDA. It's also the standard of watching it and regulating it after it's approved.
Yeah.
Right. So when the FDA approves a medication, I want people to realize this. They also have to then prove that it's still safe, that it's being made properly, and that the facilities are inspected on a regular basis. Versus with supplements, you don't really know what you're getting. It could say 10 milligrams of melatonin and end up being 2 or 22.
Yeah, it's really true. And I really think, your messaging and your clarity across things, not just the allergy spectrum, helps the field, because I think there is going to need to be more and more, I'll call it, hopefully healthcare voices of all sorts that are providing people with the most available evidence. And so I really do appreciate you joining us. And I'm sure the parents, the children, and the community benefits from you, not just obviously in Chicago, but across the globe, because I think you've been able to communicate to larger audiences, just interacting with you, I'll say, without oversimplifying it, giving them the information in a way in which they can actually follow it and understand it. I'll just remind everyone, if you've enjoyed this podcast, make sure you check out his book, All About Allergies. That's out on February 24th, and there'll be a link in our resources for this episode. Really excited for you to have that coming out. But any other big items you think we should make sure we cover?
Yeah, I really appreciate that. I think one of the aspects of medicine that often gets lost is that we talk a lot in jargon. And when I was in training, I did part of my clinical rotations at the Cleveland Clinic. And for pediatrics, they had this policy that if you were doing clinical rounds and you're presenting a patient in front of a family, you were not allowed to use any medical jargon. You had to minimize it to such a little amount, which is so challenging, especially as a medical student. And so in my book, I talk about how do we define asthma for patients and talking about these complex diseases. And so it really helped me go back and say, hey, I'm going to pretend I don't know anything about these issues. And then how do I get the information across that as many people can understand as possible? So you take the knowledge base and then you really have to use analogies and take your time with it. And that little extra time can make a difference, so that I encourage patients, when you talk with your physicians, if they're going to order a test, don't be afraid to ask them, what tests are you ordering? Why are you ordering them? What are you hoping to gain out of it? And the accuracy of these tests. And these are important questions. I talk about this in my upcoming book. There's 3 parts to it. The first part is setting up the language, which is very important for me. So we talk about immunology, anatomy. What do you expect when you go into the allergist's office and the testing that's involved? The second part is going into all these different allergic diseases, many of which we talked about together here, and more common things, not so common things. And I talk about patients that I have seen myself, or I interviewed some of my followers for their perspectives on this to help it be more case-based focused, just like a lot of medical students learn today. And then the third part is the treatments, the therapies that we have, and the future directions. What is the research into allergic diseases? Where are we going potentially, to give some hope and clarity into this? And I hope by doing this, it helps people who are living with it be able to take charge of their health a little bit better by equipping them with additional knowledge in how to ask questions. But then also for those who don't live with allergic diseases, to then understand why we have to take this so seriously as one of the most common chronic diseases in the United States. If you just lump all of these allergic diseases like asthma, hay fever, eczema, hives, medication allergies, a lot of public health issues that aren't talked about enough, but yet in popular culture, it's often the butt of a lot of jokes because it's just poorly understood. We don't see that with other aspects of healthcare with chronic diseases. You don't see cancer made fun of or diabetes, but you do with food allergies because it's not understood, yet it becomes this inconvenience for people. And so I'm very passionate about educating people about these issues so that we can come from a better place of understanding and empathy.
That's really great. And I really appreciate your sort of candor in making that statements, but also just getting the message out. At the end of the day, I say this on our podcast all the time, life's about service and purpose and the opportunity to make people feel better and empower them to do that. So we've really appreciated it. And I'll just remind our listeners, check out all about Allergies, your book coming out on February 24th. And if you want to follow Dr. Rubin on YouTube, X, Instagram, or TikTok at Rubin_allergy, he's on all the socials. Thanks again, Zach, for joining us today.
Thank you so much for having me.
Well, that was really an exciting episode. I have to tell you, Zach really breaks down immunology, but just generally medicine in a way that's really understandable. And I thought it was really exciting to just have the conversation with him and have so many ways to better understand the way allergies work and the language we use around them and how we can maybe help our friends, colleagues, and maybe even family that have some of these issues. Thank you all for joining us on this episode of Beyond the Endpoint. As always, we encourage you to share your thoughts on today's topic by emailing us at beyondtheendpoint@duke.edu. And don't forget to subscribe on SoundCloud, Spotify, Amazon Music, or Apple Podcasts. You can also connect with the Duke Clinical Research Institute on LinkedIn or by following @DCRI News on X and Blue Sky. We hope you join us for our next episode.
This has been Beyond the Endpoint. Resources related to this episode are available on dcri.org/BTE. If you have any burning questions about clinical research or healthcare, drop us a line at beyondtheendpoint@duke.edu. We'd love to address your questions in a future episode.